Welcome to AETCM, the Emergency Medicine Channel. Today we are presenting a case of 38-year-old female who presented to ER with a neck pain radiating to left upper limb. 38. She was having this pain, on and off pain, but since few hours she is having severe neck pain radiating to left upper limb.
Okay.
She is a tailor by profession. So she came walking to ER, vitals were stable, no history of any fever or any trauma. So we initially, on examination, there was no spinal tenderness and movements were okay, no neurological deficits. There was a painful restriction of the right shoulder only, mildly. And then we
Painful restriction of the
left shoulder.
Shoulder.
Shoulder she was having
Okay.
a light pain. And she was complaining, so we gave initially analgesics and we planned for an X-ray, neck, cervical spine and shoulder. X-ray cervical spine was showing some degenerative changes on it.
How did you examine a cervical spine?
So initially we can expose the neck region. So initially we have to, on inspection, any spinal, any malformations, any skin, just for the skin, any swellings externally. And then on palpation, any local rise of temperature, any spinal tenderness, and then any muscle tenderness or any muscle wasting, and then look for any sinuses, anything, and then look for the movements of the neck, means painful restriction, any neck flexion extension, and then adduction abduction, that rotatory movements, if any neck movement pain. Then look for the neurological deficits for the upper limbs. And also look for the lower limbs also, any neurological deficit.
Dermatomes, you tell me.
On C1, C2, C2 is mainly the dermatome is neck and scalp. So the pain will be referred to scalp. And then there will be no neurological deficits. Then C5, there will be neck, shoulder and upper arm. The pain will be there. And the
Sensory dermatome?
Sensory dermatome is shoulder. And then the biceps jerk will be, reflex will be, we will be looking for biceps. And C6, there will be neck, upper arm, and then mainly left thumb, means thumb and index finger, and the proximal forearm. So the reflex will be the wrist, brachioradialis and biceps. And C7, mainly the scapular region, medial part of scapula, and then mainly on the arm, palm, it will be middle finger, and it also having wrist reflex. And then C8, it will be C7, there will be this medial 1/3 of the scapula, then chest also will be involved. And C8
Simple thing, C5, C6, C7. The C8 in the middle finger. C8 will be in the
ring and
the C7 is the middle finger.
C7 is the middle finger.
That is the easiest thing that sensory dermatomes that you can remember. So that is more than enough. Okay, so reflexes, all root values you set. So that is your initial examination. Suppose that's one of the most common presentation of a neck pain coming to the emergency room. So neck pain, non-traumatic. We will not consider all the traumatic neck pains. We just leave it alone. All the fractures, everything you leave it alone. Your anterior spinal cord syndrome, all those things we are not going to discuss. The most common reason of an ED visit when you look at the neck pain is non-traumatic neck pains. So among the non-traumatic neck pains, the most common reason is what?
Cervical spondylosis.
The most common reason is basically cervical spondylosis resulting in muscle spasms. So that will be the most common presentation. Cervical spondylosis presenting with neurological deficits, very rarely we will see. Cervical spondylosis presenting with muscle spasm is what we commonly see. So the rotatory movements and everything, they are unable to move to one side, they have got pain and all those things will be the common presentation. Then what are the other? This is a young lady. I am not suspecting a 38-year-old to present with cervical spondylosis like symptom, but maybe due to the profession, she might get early cervical spondylosis. You said she's a tailor. Maybe due to the positioning and all, she might be more prone to develop for an early cervical spondylosis due to her professional, or else maybe due to the position, simple muscle spasm also can present the same way. What will be the other common causes for neck pain?
Presenting with neck pain, if there is patient was also complaining of fever and headache with
Sudden
neck
onset. You just medically you know. Sudden onset, most commonly young males coming, young males or females. Last night I went to bed. The next day I am unable to move my head. Positional. The most common will be the muscle spasm again, and they can have the worst thing similar to muscle spasm. Sternocleidomastoid is what we'll call it as torticollis or wry neck. So whenever you have got a wry neck, torticollis, usually it is a muscle spasm. But due to certain medical conditions also, you can have or surgical condition also you can have torticollis. Can you name few?
There are life-threatening conditions like any retropharyngeal abscess, any Lemierre syndrome. It is the suppurative jugular thrombophlebitis.
Okay.
Any epidural hematoma, then any malignancies.
They can present with rarely, but whenever you get a young group of patients, suddenly last night I went to bed and all after lifting somebody, that is the most common one. Suddenly they were trying to lift a weight, they were not positioned properly, or they have gone to gym and they started doing some exercise and suddenly they are having a muscle spasm and they can present with sternocleidomastoid muscle spasm. That is the most common reason for torticollis. So these are the two most common reasons of that area that can present with neck pain. Now you said certain medical condition where you can have referred pain to that area or neck pain itself they can present. Can you tell me condition?
If the patient presents with fever, headache and altered sensorium, then it can be meningitis.
Meningitis.
And if there is severe throbbing headache, sudden onset with a worse headache of the pain, neck pain, it can be SH. And then any dental caries or any referred pain from the this.
Okay, also from the any chest infection, herpes zoster infection, if that dermatome is affected, you can have all these causes as a mostly the neck pain, and very rarely cervical metastasis we will be able to see. We don't see very commonly cervical metastasis. We see a lot of thoracic and lumbar metastasis, but cervical metastasis also can happen. And elderly patient with any of the risk factor they are presenting, you can suspect neck pain and there can be a metastasis. So the most common we can name one, cervical spondylosis, muscle spasms, then torticollis and muscle spasm we can put it together. Then other medical causes whatever we have discussed will be the most common non-traumatic causes of neck pain presenting into the emergency room. Myocardial infarction, that is another it can just radiate to the neck and it can present myocardial infarction very rarely, but still you can have, but it is described that it can come with myocardial infarction and can also present with neck pain. So every patient with neck pain, you need an ECG? No, you have to stratify them. Depending upon that, you can go ahead. You don't see any other cause, there is profuse sweating associated with, then definitely an ECG is warranted. Now you said regarding the X-rays. So does all the neck pain patients need an X-ray?
No, sir. X-ray is actually the neck pain, if we can categorize like uncomplicated and with radiculopathy or myelopathy. If there is uncomplicated neck pain with no radiculopathy, no myelopathy and acute onset within hours to weeks, 6 weeks, 2 to 3 weeks, then we no need for any X-rays. If you are suspecting any myelopathy, is there any weakness, any progressing weakness, any neck radicular pain, and if there is any Lermier's sign like
we can simply say with any focal neurological deficit, you definitely need an X-ray. Trauma, we are keeping it aside. Trauma I am not going to discuss at all. Trauma, X-ray is not at all an option. X-ray we will just keep it away. So what are the views that you need to ask for?
We usually ask for X-ray, C-spine, AP lateral, and then there is one swimmer's view for clandioaxial joint, and then we can
AP again, open mouth view is there, so that is another view. Usually we have to look for rodentoid and all, you need to ask for an open view flight. And again, the most, why we are not saying X-ray is not, if you are taking an X-ray has to be taken properly. So till you have to able to see the C7 T1 junction. If you are unable to see, that is the reason why the swimmer's view and all come, because otherwise somebody need to pull down the patient's both the hands while taking the X-ray, because the C7 T1 junction has to be visualized very well. So now you imagine the most important one is a lateral view. You have AP view and lateral view, but we prefer to see a lateral view of X-ray. So how will you interrupt a lateral view of an X-ray of a patient? So what are the common findings that if you are asking for, what are the common things for a lateral view of a spine X-ray that you need to comment upon?
Look for the vertebral body.
The first thing what you have to look for is the straightening of the spine. If there will be slight lower doses. That slight lower doses will be lost because of the muscle spasm. So the straightening of the spine will be the classical finding that you will be able to see in any patient that is coming to you with neck pain. Straightening is what you will be able to see. So straightening of the spine, look for that first thing. Then you go ahead and see the lateral view. Then there are lines. That is the anterior vertebral line, then the posterior vertebral line, then there is a spinal line. So we need to see whether there is any deformity, any stiff deformity, any fracture. That is for trauma. But routinely for a cervical spondylosis, what we will be able to see is most of osteophytes, new bone formation. Lot of osteophyte formation we will be able to see. So this will be the only thing that you are going to get in an X-ray. Suppose you have any doubt, you proceed with CT or MRI, depending upon that. But what you need to look in for any this traumatic condition, the classical thing that you will be able to see will be a straightening of the spine. And there can be an additional findings like a parapharyngeal abscess. You are able to see, maybe a lateral view you are taking, you are seeing the parapharyngeal spaces also. You will get that idea also in an X-ray. So that is the investigation that is going to help you. So now you come, you have done what are the investigation. X-ray is the most common, and depending upon other reason you need a CT or suspecting an SAH, meningitis, then you have to do an MRI and an LP. Depending upon other reason you can decide the management accordingly and the evaluation also accordingly. Now coming to the management of the patient in terms of treatment aspects. How did you treat this patient? Analgesics is the key. They have pain, so analgesics is the most important thing.
If there is no other focal neurological deficits, we can manage with analgesics and review MRI if symptoms persist. If there are focal neurological deficits, we surely have to refer to a spinal surgeon, and we'll have to evaluate with MRI. And if there is decompressions, laminectomy, everything should be done.
Have to be done. Then the most common traumatic cervical pain, where there is no cervical spondylosis also, how will you manage them?
Muscle antispasmodic.
There have been recommendation, but there has not been very useful, but you can try, but analgesics you can give, and mostly they should be referred for a PMR. They should be referred to the physiotherapist or physical medical rehabilitation center. You should refer them, and they should undergo ultrasound therapy or this ultraviolet light therapy. So some sort of a therapy, depending upon that should be advised. Restriction of movement is not ideal. So this muscle spasm and all those things, there is no advice to be given for restriction of movement, and no role for the soft cervical collar. So again, when you can give for cervical spondylosis, why we are giving a soft cervical collar? Because sometimes the patient turns around the head suddenly and they can have syncope symptoms. So in order to prevent that, we might suggest as a soft collar. But routinely for this muscle spasms and all, cervical collar should not be given, and they should be ideally done what? They should be ideally going ahead to the physiotherapist, and they will be doing adequate physiotherapy. So that is the mainstay of treatment, and you have a lot of other options. You can, there is some vacuum pull technique. There are a lot of physiotherapy things that is required for the management of a neck pain, and analgesics, and both these things are more than enough for a patient recovery. It will take some time. Usually at least 1 week's time it will take to for a recovery, complete recovery. If it is torticollis and all, it will take a longer time to recover. 1 week to 2 weeks also it might take, but initial 3 to 4 days after the therapy itself, they will be better. Okay, so what else you have to add on? Something you can tell me?
No, sir. Oh, everything.
Whatever you have prepared, you can just tell.
There are some named signs
you can tell.
rule out there. Depending on the pain, if there is localized pain on the ipsilateral side, when the head turning to same side, if there is pain, it is maybe due to facet joint injury. And if there is pain due opposite side, it will be maybe ligament or muscles.
Okay.
And there is spurling sign. Spurling sign is like the patient is, we will push down the head. With a chin up position. And modified spurling is like if the head should be turned, leaned towards a symptomatic side. And then abduction relief sign, that is even in disc protrusion, when the hand is abducted and put on the head, the pain will be relief. And there is Lermit sign, that is with the myelopathy. Ask a patient to touch the chin to the chest if there is pain, and or till the pain restrict the movement. At that time, if there is a sharp pain along the spine, it is positive for the myelopathy.
Okay, so non-traumatic neck pain. So what we have discussed is non-traumatic neck pain. Our most important thing, we have to only have 2-3 life-threatening conditions, maybe meningitis and SAH and myocardial infarction. So we need to able to rule out, and rest all things we have time for evaluation. X-ray, when you have a focal neurologic deficit, neuropathy, only you need an X-ray to be taken. Otherwise, routinely X-ray is not required. And the key treatment aspect is to analgesics with early physiotherapy. Fine. Thank you.